I'm going to try to get you guys to contribute a lot to this. First, give us an idea how big a problem this is in India.
Proximal femur fractures, falling failed intertrochanteric, as well as failed cannulated screw fixation for neck femur, both of them.
Right. I think, the point was made earlier today that primary osteoarthritis of the hip is uncommon in the South Asian population, but post-traumatic arthritis, AVN, we heard, ankylosing spondylitis, these are all much more common reasons for doing hip replacement surgery. And we also heard this morning that often we're treating intertrochanteric fractures primarily with hip replacement, which I'm not going to cover in this session, but just to say that, it's a very big problem, and I think there's certain techniques and skills you need to have in order to do these surgeries successfully. So I want to go through all those ideas and get your tips and your techniques. So let's start with the obvious, right? You have failed hardware, post-traumatic arthritis. I don't think anyone on the panel will disagree. We've got to rule out infection, right? We've talked about that. We get the ESR, we get the CRP. We'll do an aspiration almost every single time, okay? And then I think it's a question of getting proper x-rays. I think that's one thing I've seen in India sometimes, not getting proper x-rays, enough x-rays. Certainly full-length femurs, knowing what's going on with the rest of the femur is important. And then getting a CT scan. And ultimately understanding what the implants are in there. Just if it was a total hip or if it's, fixation, if you know what they are, it's easier to remove them with screwdrivers, the appropriate, right? So does anybody have anything else they want to add to this preoperative assessment? Come on, guys. Anyway. Dr. Chatterjee.
Yeah, I think it's very important to try and contact the center where the previous surgery was done to know about the implant, whether it's stainless steel or titanium, and what's the company, because one of the great difficulties you can face is to try and take out this implant.
Absolutely. No, so I think it's an excellent point, to do your homework and to know what the implants are, who makes them, to get the proper tools, because there's nothing more challenging sometimes than taking out hardware when you don't have the right tools.
So sometimes, some implants, you may not be having those kind of screwdrivers. Once I, failed to take out the implant because it has the star separate screw head. I didn't have a star separate screwdriver ready on the table. Right. So that is the problem. So you have to know the company and what are the implants required to extract it.
So
Amar, yes, just a point again. So, many of the times they have a very subtle infection sort of thing, you're not very sure. So I think as a part of consenting, the patient should be told that, they might, you might not do a hip replacement or partial hip replacement, and, you might have to put in a spacer or something like that. Yeah.
I think that's an excellent idea, and I don't think there's anything wrong with doing that if you have any suspicion. You can get a frozen section at the time of the operation, if that can help you make a decision. But I think, if you have any concern, I would say putting a spacer in is the right thing, getting cultures, and then if it's, it's 2 weeks later, you can go back and reimplant, or you can wait the full, time. You have a question?
Yeah, I think one more thing is that most of the times in the failed IT fixation, we have broken implants, and we need to have special inventory to take out these implants, the hollow mills, then the high-speed burrs or something like that. Because if that one of the broken screw is stuck there, then it will be a very difficult thing to manage it with the THR.
100%. So as much as we would like to know what is in there, we can't always find it out. And other times, as you said, there's broken hardware. So we're going to get to all that. Yes, Dr. Jain.
One more problem that we have noticed in all these cases, that infection remains one of the major issue. And sometimes the infection is not obvious. When you send a implant wash, that shows the culture, the growth in the culture. The important is that the history of the last surgery, how well the wound has healed, and was there a problem in healing?
I mean, I think it's an excellent point, and we've made that, right? I think there's no problem with putting a spacer in and getting appropriate cultures, getting cultures of the screw holes. You know, I'm especially suspicious if there is some level of non-union involved, right? If there's union, my suspicion goes down a bit, but you can always be burned.
Yeah.
On the end?
We should be also ready to deal with any kind of intraoperative fractures, because
Yeah,
sometimes
you can certainly cause them. So that's going to get to, let's try to go through this to a stepwise fashion, right? So does anybody want to add anything left on the preoperative assessment?
Yeah, when you remove the intramedullary nail, always see there is some fibrous tissue lying there. You have to scrape that before you do THR.
Okay, so that's going to be intraoperative, but I'm asking you anything else preoperatively you want to do? Okay, I think we got that covered. So let's talk about exposure. Who's going to do the posterior approach? Raise your hand. All right, looks like most of the panel. Who's doing the anterior approach? One. All right, I'm not going to pick on you. But I think, the point is the incisions should not be compromised. These require wide exposures, right? And you need to, there's often shortening and capsular adhesions and things, so you have to do. So tell me from the posterior approach, tell me some techniques to do to get capsular releases.
I'll take a standard approach as much as possible and go flush with the posterior trochanter and keep the soft tissue intact. Most of the time, so if the trochanter is already fractured, then you can reflect it and go in the hip joint.
So you can use.
I'll try to dislocate the hip with the implant and then try to take out the implants.
Yes, so that's, as you can see in big, bold letters there, right? Hip dislocation prior to hardware removal. Right, that's one of the most important things I try to reinforce with my residents and fellows, because you don't want to cause a spiral fracture or something through those, the empty screw holes. So I do the dislocation, and then I will put the hip, well, first I'll do the dislocation, then I'll release the anterior capsule, right, underneath the head with a long knife and just take all the anterior capsular attachments off it, and that really gives me mobility of the femur. Then I can put the hip back in place, take out all the hardware, right? Redislocate and cut the head, okay? That's if we can get all the hardware out, okay? So now, tell me about what you're gonna do if you can't get the hardware out.
The best way is that if you have a dynamic hip screw fixation, for example, you dislocate the hip with the implant in situ, and then you make the neck cut. And then it will be far more easier for you to remove the implant. And as we just discussed, you need to have all kinds of the diamond cutters, the burr, to remove the hollow mills, to remove the broken implants. I think that is a very, very important thing. Yeah.
So some points I wanted to bring out, and as has been mentioned, sometimes we'll do selective hardware removal. You can see we cut that plate in there, right? As you mentioned, you can cut the head into several pieces, quarter it, if you will, to help you get access to the hardware. Oftentimes with a sliding hip screw, you can pull the screw out from the top, right? As opposed to screwing it out backwards, right? So I'll very often go right to that technique, just because it's actually faster. Anybody else have any tips?
It requires a lot of release. Fibrous tissues are stronger than the osteoporotic bones. When there's a failed internal fixation, these patients are not weight-bearing or it is painful, then the bones becomes osteoporotic, and there is a lot of release, proximal femoral release. That's why adequate blood and blood products has to be kept standby on the operating table.
Okay, very good. Yes, and so as we mentioned, high-speed burrs, diamond tips to cut metal, broken screw trephines, having large, we call it the Winquist, nail removers and slap hammers. These operations can go very, very smoothly, as we said, removing hardware, or it can be a real bear, right? And I've seen like titanium nails get pseudo osteointegration, where it's like removing a femoral component, right? And it's extremely difficult. So having all those equipment in your armamentarium makes these cases go, smoother. But yeah, I mean, there's an old saying, no one looks good removing hardware, right? Because it can be hard.
Especially the stainless locking plates. Now they have the cold soldering sometime, and that's a very difficult thing to remove these screws.
Absolutely, and you can also get bony overgrowth of the plates, and especially if hardware was put in when someone was younger, right? The whole bone can grow outside of the hardware. So those are all things that need to be assessed.
One of the nightmarish situations would be a cold welding of the barrel of the DHS with the screw. And that becomes very difficult, and at times I've had to actually take the plate and rotate the plate to get the screw out. So, but that's fraught with danger of causing a fracture.
Yeah, no, that's an excellent point. So we talked about now doing the dislocation, doing the exposure, doing the dislocation first, getting the hardware out. All right. So now let's talk specifically about individual situations. So who's got a technique for cannulated screws or some advice?
The best way to remove the cannulated screws is to dislocate the hip with the implant, do the neck cut, and retrograde, hammer it out. In case it is the screwdriver is not holding it well and it's not coming out easily.
Okay, good.
It's a very easy removal of this.
Anybody want to add anything to that? What about, Dr. Mohanty, you're about to say something?
No, sometimes, you have to take a small gouge to take out to free the screw head. As you can see in this particular X-ray, the last screw, the part of the screw is buried inside the bone. So you have to take a small gouge, just free the screw head before putting the screwdriver there. And while rotating the screwdriver, sometimes the threads give way and it becomes difficult. So you have to have some kind of holding device in order to take the screw out, because screw head gives way, and you have to have multiple screwdrivers with sharp edges so that it will hold well to the screw head.
Right, you can strip the screws and make your life more difficult. Who's going to put in a primary hip in a cannulated screw situation, and what tips do you have for someone who wants to do that? Go ahead.
In primary hip, the holes of the screw must be filled with bone graft, and sometimes there's a sclerotic bone in the medullary canal, so you have to really burr it out and take care you don't change your tract of the reaming.
So I kind of disagree with you got a bone graft the screw holes, but I'm not opposed to it, but I think it's a waste of time.
Yeah, I think the most important thing is you need to be careful of the lateral screw, the screw holes, and when you are putting in the rasp or the first reamer, you need to be very careful. Similarly, as you need to be careful of that sclerotic bone. It would guide you out of the femur, so that is there, and you can put in a standard hip, I think, in all cases with cannulated screw fixation.
So I agree. Yeah. So I mean, I do agree that sometimes if you're going to cement, those holes can also cause a problem excursion. Sometimes just putting your fingers in there can help you do that. But I agree. I want to talk more about the sclerotic bone. Right? It's not very deep. It's right in the neck, and oftentimes you just take a high-speed burr and and it's all gone. But if you take the screws out and just start to broach, I promise you're going to break it.
And one more point I would like to add, along with that, entry point has to be perfectly lateral. Because if your stem entry is in varus, then there is chance of, shattering the bone in that side.
Exactly. And then the other thing to be aware of is with the screw holes on the lateral side, you can get some bony, ingrowth into the canal. And that needs to be removed either with a burr or with gentle broaching, because what will happen is you'll template, say, a size 4 stem, but then your 3 stem doesn't want to go in all the way because that bone is there. So either if it's stable enough, you can get away with it, but you don't really want to be resting on that bone. If you understand what I'm saying.
It might be helpful to put a prophylactic wiring before doing the broaching to prevent a fracture.
Yeah, I don't have any problem doing that. It's very quick. It's very easy. But yeah, I think as I said first, burring out that sclerotic bone and just being aware that it's there often. But you can look at the X-ray and you can see how sclerotic it can be. All right, let's talk about sliding hip screws. How are we gonna get those out? Give me some tips.
I think with a sliding hip screw, it's sometimes more difficult to get a primary in 100% because of the length of this plate being used. If someone used 2 holes, it's fair enough, but long holes, we might require a solution of some sort of long stem to go across the last screw hole, a couple of centimeters down line. And it is sometimes difficult to remove those things, but because of large hole made on lateral aspect. So beware of a fracture, and probably prophylactic wiring is far better in DHS situation rather than CC screws.
So you brought up the point of, bypassing the distal screw, right? That's what we're all taught to do, and I think if that is easily done, it should be done. But I see it all too many times where people put in a very, very long stem when they didn't need to. If you have any so what you don't want is a stem ending at a screw hole, right? If it's far, far away from it, it's not a problem. Right? If you're really concerned, you can always put a plate on the outside, right? But you don't have to bypass every single screw hole if it's going to make your life complicated, right?
I think standard stem is okay for a 4-hole DHS. Beyond it is okay, but I think more than 5 or 6-hole DHS, you might require some sort of a couple of centimeter more stem, long stem.
Right. So I'm just saying, consider going shorter and either putting a plate or allograft, strut allograft, or even just putting them on protected weight bearing for 6 weeks. As long as they don't get a spiral fracture in the first 6 weeks, then those screw holes are irrelevant, right? But just don't end the stem at the screw hole, right?
Or else you could do cemented.
You can do that too, but then you're really playing the flute, trying to hold all those.
Cemented stem.
Cement will come out of the holes, that's the other part,
Yeah.
And that's more bad looking X-ray.
But that's not too much of a problem. You put a thumb near the DHS hole,
I know,
other
inside,
screws are.
inner cortex, middle cortex.
Yeah, that anyway you are doing the burring and all in order to put your brooch anything. But sometimes I see that in case of little older age patients and when there is a little porotic bone, I prefer a standard cemented stem which will block all the holes. I don't have to put a longer stem.
One of the care, Amar, that I feel that one must ensure, DHS will leave a large hole, and the reaming, the broaching should be done very carefully so that you don't cause a trochanteric fracture.
Absolutely. So when I convert these, most of the time, if I'm doing cannulated screws, I will do a double tapered stem, like I said, standard implant I normally use, but first I'll remove the scrotic bone with a burr, and then it's straightforward. With the sliding hip screws, because there's so much more screw holes and issues involved, I will use an SROM type stem or a system where I'm going to be reaming and milling the bone, because I think that works much more effectively than a broach-only system. Anybody want to argue with that? Or? So I think it's the key is to recognize that the bone is sclerotic. It doesn't accept the broaches normally, and if you just go straight to the broach, you might get yourself into some trouble, right?
Yes, in such situations, the high-speed burr is a very useful tool.
It is, absolutely, 100%, right? So I think I use it primarily as well, right? So I have a burr open all the time. Just one little technique you can take. If you can get the plate off the bone a little bit, get all the screws out, you can use the plate to take out the sliding hip screw, right? You guys seen that technique? So I used to do that a lot in the beginning, and now I just cut the head and I pull out from the top. But I mean, I think it's...
Especially if you cannot separate the barrel from the screw.
Yeah.
And that's the only thing left to do, actually.
And what about nails? Who's got some techniques for removing intermedullary nails? I told you mine, right? I use fluoroscopy sometimes.
Yeah, whenever there's an intramedullary nail, always there's some biological fibrous tissue layer inside. So if you're doing cemented or anything, it is better that you remove that fibrous layer.
Absolutely. You made that point before, and yes, it really needs to be. I will ream, I'll broach, and then I'll back scrape the inside of the canal.
I think it's very useful to have a piece of equipment which is a variable threaded device which locks onto the top of the nail. They are actually conical.
Right.
So you should have 3 or 4 so which you can fit, because a lot of the time the system you have available in your hospital may not correspond with the nail, and then it's a terrible job to remove the nails.
That's what we call the Winquist system.
Yes.
And yeah, so it gives you multiple threaded devices, conical. You said you can get into almost any nail. Oftentimes they'll just cross thread, but that's fine. And then a slap hammer attaches to it, and you can get it out. Just don't forget to take out the distal interlocking screw first. Don't get too excited.
You have to leave the distal screw, lock the device, and then remove it.
Okay, right?
Otherwise, it will rotate. And the other thing is that if the nail is broken, then at times you may be forced to leave the distal part of the nail in situ.
Yep, I have no problem doing that. All right, let's keep going. And then I think the biggest problem with these nails is that they disrupt the adductor musculature, right? So obviously don't do any more damage taking it out.
You can't use a simple stem. You have to use a long tapered stem for nails because the endosteal, the fibrous membrane will not allow us to use anything like a proximal coated or a distal coated nails. It has to be long nail, I suppose.
Yeah, I mean, like I said, I would often use an SROM. I just like to load the bone proximally if I have good bone. My general rule of thumb is if I have the lesser trochanter available, I'll put an SROM in. If the left trochanter is damaged and everything, then I'll go with the distal fixation. So I think it depends on the bone, whether there's non-union in that intertrochanteric region or not. Those are all factors that come into play. On the acetabular side, for the most part, I think you just leave the hardware there. Right? No one should be going after hardware on the acetabular side unless you encounter it while you're reaming, and then I take it out usually from the inside.
One point to make an acetabular part is if you have a failed DHS or CC screws, it might just wind the effect of a wiper, and they destroy a lot of wall of the acetabulum, which we have not encountered before, like not planning for that. So when you have which is a loose DHS rubbing the acetabulum, we should be prepared for all these things on the acetabulum side, I suppose.
Yeah, and I've also seen those screws, the cutout screws, really eat away at the acetabulum, make big defects. So yeah, you got to be prepared to do a revision acetabulum in a sort of primary setting. Anybody else want to add something?
Yeah, in elderly patients, if the cartilage is fine, then we can do a bipolar also on that side, on the acetabular side.
I think that's absolutely fine. I'm a hip surgeon, so I generally will not do that. I'll give him a socket, but I think in certain situations that is appropriate. Okay, so let's talk about the femoral component, right? We have to assess the bone loss and the quality, the trochanter and the abductor integrity. We want to talk about the canal. Do we have to do any osteotomies? We're talking about bypassing the defect, right? Not leaving the stem at the defect, right? And like I said, it's okay to use a plate or a strut allograft, right? Because, the problem is the bow. Going long is great, but the femur bows. And if you don't pay, attention to that and are aware of that, if you go long often enough, you're going to go out the front at some point, right? So the answer isn't always go long. Sometimes it goes against your thought, but go short, really short, be far away from the hardware, and you can get away with it. Anybody want to add anything on the femoral side?
One of the problems is sometimes the femur is molded and you have a varus kind of a deformity. Mm-hmm. The other thing is that the tip of the greater trochanter, it tends to hook inwards, and then it becomes very difficult to get the nail in, the femoral component in straight. So you might want to have to do a subtrochanteric osteotomy, alignment osteotomy every once in a while.
That's my point here. It's very, very common actually to have varus remodeling. Doing trochanteric osteotomies or subtrochanteric osteotomies are often needed. One other tip that I will say I've done in the past is you take the nail out, it comes out from the hole in the greater trochanter, right? Because of varus remodeling, it's hard to get the reamers down the canal, right? So what I will do is I'll ream through the greater trochanter, right? Get my distal fixation, and then usually with the real implant, especially if you use a modular distal fitting stem, I can put it in through the same greater trochanteric hole, right? Get that fixation distally, and then sneak the proximal part just underneath the trochanter, right? And then attach it again from the top, right? So these are little things you can do if it's you're close. The varus remodeling isn't too bad, is to actually go through, like I said, that channel in the greater trochanter. You guys follow me on that? So you can use that path.
May I make a point? When you use a PFN or something like that, the entry point is very posterior to trochanter. So when we enter actually the canal, it has to be slightly more anterior compared to what the nail came out from. So it's a large hole on the trochanter which can break easily. So be aware of that when you're using a PFN, which is really large implant on the top, like 13, 16 millimeters.
So we touched on it before. Like I said, I'm going to almost routinely do a non-cemented fixation. I'm going to try to do an SROM if I can, if I believe the proximal bone is supportive. Otherwise, I'll do a Wagner or a modular type stem. Who likes to cement routinely? Nobody likes to cement routinely.
Not routinely.
Not unless the patient is elderly, above 70.
Above 70, you'll do it? Okay. Yeah, I mean, I think as we mentioned, with all the screw holes and everything else, that's something to be considered. The lateral ones can be plugged, the medial ones are a little harder to plug, and so, I don't think it's ideal, but I think there's certain situations where it's a reasonable thing to do. All right, I think let's go over some cases here. So we got a proximal femoral nail, got some post-traumatic arthritis. So someone walk me through quickly the steps. Dr. Jain, walk me through the steps. How are you going to do this?
Okay. So naturally, we'll have to remove the implant, the nail first. Okay. You're talking about the X-rays on my left side where the nail is inside. After dislocation, you remove the whole implant, and we have to be careful what you're talking about, putting the femoral component there after cutting the neck. And it should be in a straightforward, uncemented on both the sides.
Exactly. So, we're going to rule out infection, do a wide exposure, dislocate the hip, put it back into place, take out the distal screw.
Yes.
Right? I'm going to quarter the head, pull out the proximal screw, then find the hole, get the nail out, right? Start reaming, start preparing. Now you can see, because of all those things we talked about, the stem is in a little bit of varus, right? That's okay. We've bypassed the distal screw. You can see that there. But you can also see that sclerotic bone. Let me see if I can do this.
What he was talking about, the
Right here,
same thing, yes.
Right there, right? So it's leaning on that. I didn't do a great job of getting rid of that sclerotic bone right there. If I had, I could have maybe gotten one size sleeve bigger in, and it might have been an even better fit. So those are things to be aware of, right?
See, so all the implants, when we're doing these nails or implants removal, as you were talking about it, that proximally where the canal is sclerosed, right. And when these nails are there, what he was talking about it, entry point, you have to be just little patience there. If you get a right entry point, probably you can lateralize it and you can do a good way.
The offset looks little less.
It does. It's a little bit rotated, but yeah, I mean, I think these hips are stiff, and you sometimes can't reproduce the offset and the length. You can't always restore, right? Because they're too tight or too stiff. But I agree. Ideally, you'd want to restore the offset, but you can't always. You can't reduce the hip.
Is it necessary to put SROM all the time?
Is it necessary? No. What I like about it is, like I said, it's a reaming and a milling device, right? So that allows me to prepare the bone in I believe, a safer way than with a broach system. All right, here's some cannulated screws. Who wants to take it on? Dr. Sharma?
The plan will be the dislocation of the hip first, and then taking out the screws after cutting the neck, and then after it will be the high-speed burr. Is a very useful device in all these cases. You make the right entry point with the burr, and then go on with the routine hip arthroplasty.
Yeah, I agree.
I don't see any major issue in this after removal of the screws and after making the right entry point.
And I just want to bring everyone's attention again to that sclerotic bone laterally there, right? So if you can remove that or get it taken care of, while you're broaching, but I feel like in this case I was able to get a good broach in despite that sclerosis over there. All right, so here's another case of an intramedullary nail. We bypassed it, okay? So that went longer, but as you can see, the stem is also a little bit down, right? So you have to be able to reduce these hips. These hips can become hard to reduce. And as I said, these are one of the, this is, I think this is the case where I reamed from the top to get that shot straight down in the trochanter. And
You have rightly excised that bone, otherwise it would have caused impingement in adduction and dislocation.
it can happen. And one more piece of advice, when you're dealing with these types of intramedullary nails, the TFNs, what are you going to tell your patients about pain control and limp? So my point is, with these devices, they usually muck up the abductors, right? And whereas you can very successfully relieve their pain with a conversion to hip replacement, depending on how badly those abductors are messed up, they may continue to limp, right? So you need to reinforce, they think they're getting a hip replacement. And they're like, why am I still limping, right? It's because, because somebody else messed up your, so you just got to make them aware that your abductors may not be functioning fully, right? So that's something you just want to, whenever you tell patients beforehand something might happen, it's much better than telling them afterwards, right?
Now, is it okay, is it always dislocated hip before removal of intramedullary nail? Like I had one patient who was 25 years old, K nail. I broke 5 removers and I abandoned without even dislocating it because I knew it's not going to be easy. So without dislocating, I left it as it is and I said, we can't remove it, forget about it after 2 hours. If I had dislocated the hip first, I would have been more trouble. So if there's an IM nail, which is not going to in the hip joint as such, like an old K nail or something, which can happen still in India, I think we should not dislocate the hip first, try to remove the nail if possible, which is impossible, then forget about it, rather than having a dislocated hip with a unable to remove the implant.
Yeah, I think, the point is, if you have an implant like converter screws or DHs or anything which is transfixing the neck, those cases you should dislocate, because if you remove it, there's a stress riser and you might have a, intraoperative fracture.
I agree there. But
if it's just an intramedullary nail, I think it's better to remove the nail.
Yes, I suppose that's the point I was making, that if it's only IM nail, don't dislocate hip, you might be in double trouble if you can't remove the nail.
So we always take a consent from the patient that there is possibility I will not able to remove your implant and I have to just abandon the procedure.
Yeah, I think there may be...
Each and every operation theater in our setup is not fully equipped.
Yeah, listen, I would argue if you can't get the nail out, then you got to get trefines, and you got to trefine over it, right? Just like you would take out a femoral component. Sometimes you got to do a trochanteric osteotomy. You got to cut the nail. You got to do, all these things. So I'm not sure there's a situation where you can't get it out, but it's a lot of work.
For the nails, for the key nails and all, I think you need to split a little bit of femur. It will come out, but you need to have longer stems as a part of a preoperative planning. You need to have cables also when you're taking up these cases.
The K nail only has one slot. If it breaks that, you can't do anything about it.
So but a incarcerated K nail, the only thing that can take it out is you need to split the femur a little bit. Yeah, then only it will come out. It will not come out otherwise.
I think one of the main issue about the removal of the locking nails or the Kunsha nails is that you need to have the exact information which company nail it is. You need to have multiple types of the nail removal systems. Yeah. And as you rightly mentioned, that one has to be prepared to do the osteotomy, use the trefines with the hollow mills, so that the nail, if in case you are stuck up, then you have all the instruments available.
Yeah, so we made that point, right? Know your enemy, know the implant if you can. The practical reality of the world is sometimes you can't get that information, so you have to be prepared. And that's why it's having, different systems can allow you different ways and techniques. Sometimes I've had people, take nails out from the knee, right? So you have to open your mind sometimes and think different ways to deal with these problems. I've gone down to the knee, right, and I put a nail up and I hit the nail out the top, right? So those are all things that you can try doing.
In fact, the problem in these implants is that if, in case they are removed too easily, then you will suspect that there is some kind of a possibility of infection in these cases. If they are struck up badly, then it's a little problem to remove it.
Yeah, that's true. Here's another case. Again, you can see the lateral. So this is the point I want to make from this session, is the lateral bone squattic bone at the level of the screw junction. Forces you into a little bit of varus again. Again, not a major problem, but the more you're aware of it, the more you're able to clean it out, the better.